PPI are one of the most commonly prescribed drugs, easily available over the counter, and also considered to be relatively safe drug with very very mild side effect, if at all any. So I have tried to concentrate everything around the kidney disease, or from the point of view of renal angle, and organize my talk with the background where I will briefly talk about PPI so that we can understand what they are and how much they are used in CKD, appropriateness of the use, and what are the effect of long-term use of PPI. Whenever we are talking or concerned about the adverse effect of PPI, proton pump inhibitor, it is primarily the long-term use, not the short-term use for few weeks or few days, which is anyway, if needed, has to be used. And most of the indications are for few weeks. So proton pump inhibitor, like any other drugs, once they are ingested, they circulate into blood after absorption, reaches to every cell of the body, and they are diffused inside the acid-secreting parietal set in the gastric mucosa. Now, up to this point, there is no difference in the concentration of the drug. This drug is secreted inside the canaliculi, acid-secreting canaliculi. Here, this PPI combines with the acid present in the canaliculi, and it is protonated, converted into sulfonamide. Sulfonamide is dehydrated form, and it combines with the hydrogen potassium ATPase that is called as acid pump or hydrogen potassium pump. And in canaliculi, inside the parietal cells, the concentration of proton pump inhibitor can be up to 1,000 times as compared to serum drug level, 10,000 times or even higher. So that is very important, means the drug is trapped inside the canaliculi once it reaches the parietal cell. I have intentionally obliterated some portion of the picture to avoid confusion. In parietal cells, there are three types of stimulants which stimulate the acid secretion. These are the acetylcholine, histamine, and gastrin. Through different mechanisms, they finally converge in a common pathway of hydrogen potassium ATPase or potassium or acid pump, and they stimulate acid secretion from this pump. And proton pump inhibitor is inhibiting this pump. It is irreversibly blocking this pump. And that is why proton pump inhibitor are much more potent acid inhibitors as compared to H2RA receptor like cimetidine, ranitidine, or famotidine. And that is also the reason why they stimulate, they inhibit not only the baseline acid production, but also the food-induced acid production. And their effect is prolonged for up to 24 hours because they irreversibly block the acid pump. So this is the basic concept which I want to convey, how the PPI is different from H2RA. So in next couple of slides, I will describe how much it is used in chronic kidney disease patient. I don't want to blame anyone that nephrologists are prescribing or gastroenterologists, everyone is prescribing it across the board. It is just the data, and it is very elegant study where the OPD visitors in a Korean hospitals, quite large number, 178,000 patients over the duration were included. Their prescription were screened, that what was their illness and whether the PPI was prescribed or not, what doses and what duration. So out of the total population, 5,874, that means 3.3% patients were CKD patients. And PPI prescription was given to 12.4% of the CKD patient as compared to 5.1% of overall patients, which gives a message that CKD patients are more likely to be prescribed a PPI as compared to a non-CKD patient. The same study has also given about the information about the duration of PPI prescription, and those with CKD were given relatively longer duration of PPI as compared to non-CKD patients. So with these two data, it suggests that PPI prescription is likely to be higher in patient with kidney disease and for longer duration. And number of studies have described, both in hospital setting as well as in OPD setting, indoor, outdoor, both setting, that more than 50% prescriptions are unnecessary. They are not needed actually. More than 50%. This is quite a big number. This is across the board. It is not related to kidney disease patient specifically. This is across the board. So across the specialty, it is being used. Now, when we are talking about the side effect of PPI, we are concerned about the long-term use of PPI. Short-term use of PPI is hardly causing any side effect, other than if anaphylaxis or allergic reactions. So what is a long-term? How to define? What is the cutoff to define long-term use of PPI? There is no universally accepted definition, and the systematic reviews suggest that most of the studies have defined either more than 1 year or 6 months as a long-term use of PPI. So depending upon our choice, we can say what is a long-term PPI. Adverse effect of PPI, it has two broad categories of adverse effect. The primary effect is on microbe. It alters the gut microbiota. It promotes the growth of Clostridium difficile, small intestinal bacterial overgrowth, other enteric infection, community acquired pneumonia. It's all through the alteration in the composition of gut flora. As we have learned that the good bacteria is reduced and the bad bacteria is increased. I will not talk about it. I will restrict myself to the metabolic effect, and the metabolic effect means non-microbial effect are primary. It causes acute interstitial nephritis, acute kidney injury, chronic kidney disease, and progression of chronic kidney disease. It also causes hypomagnesemia, reduced bone mineral density, which can cause fracture, and impairs the sugar control. And all these things we know can affect the worsening of chronic kidney disease, or it can precipitate the onset of kidney disease. That's why I have included there. Besides that, just to complete the list, these are the other side effects which are known to occur with PPI across the board in any category of the patient. So now I will restrict the next 10 minutes only about the PPI and its effect in relation with the kidney disease. I will take in 4 sections. First, acute interstitial nephritis, acute kidney injury, chronic kidney disease, progression. This is a very elegant study. It was a nationwide nested case control study, which included data from a cohort of 572,000 patients without renal disease, and they were followed and seen how many of them have developed acute interstitial nephritis. Their prescription were reviewed, and for each case, 10 controls which were matched for the age and gender were selected randomly from this large database. And we can see that the current user had 4.8 times higher odd ratio of developing acute interstitial nephritis as compared to control. And the beautiful thing is, with the stoppage of use of PPI reduces the risk of acute interstitial nephritis. As we can see, with the recent use, the risk was lower, and with the past use, the risk came down to equal to the non-user. So ongoing use of PPI predisposes for the acute interstitial nephritis. Now coming to the second section, that is acute kidney injury. Another population-based cohort study from Ontario, Canada, which included data from those who were more than 65 years and initiated PPI between 2002 and 2011. Data from 290,000 PPI user with propensity score match controls. They were matched for baseline demography and risk factors which can lead to kidney disease and which can lead to use of PPI. So they were matched in 1:1 ratio, and the median follow-up 120 days. And we can see here that the risk of acute kidney injury hazard ratio was 2.5 times as compared to those who have not used PPI in a short follow-up 120 days only. So with the increasing duration of follow-up, the hazard ratio may even go up. And again, this study has supplemented the previous information that the risk of acute interstitial nephritis is again higher as compared to non-user. So the 2 points we have cleared till now that PPI increases the risk for acute interstitial nephritis and also the risk for acute kidney injury. The same study has shown that as the time passes, the risk of hospitalization, chance of hospitalization with acute kidney injury was increasing in PPI user as compared to control in the Kaplan-Meier curve shown on the left side of the screen. And the interesting point was the risk of acute kidney injury was not affected by the type of PPI used. It was almost comparable for lansoprazole, omeprazole, pantoprazole, and ripiprazole because all of them achieve almost the same degree of acid suppression, which indirectly indicate that probably the pathogenesis of acute kidney injury or interstitial nephritis is somehow related to the extent of acid suppression. This is a meta-analysis published in NDT. 5 very good studies summarized data for more than 2 million participants who have used PPI and shown that the PPI user had risk ratio of 1.44 for developing acute kidney injury as compared to non-user, which was significantly different. Now coming to the third component, can PPI affect the progression of CKD in a patient who was having pre-existing chronic kidney disease? So it was a retrospective cohort study published in a very high impact journal, which included all the citizens in Stockholm from 2007 to 10, and the outcome was CKD progression. It was defined as either doubling of serum creatinine from the baseline value or more than 30% decline in estimated GFR. The database included population of H2RA user as well as PPI user. The PPI user were quite big as compared to H2RA and also used their controls. And the median duration of follow-up was 2.7 years. If you see the risk of progression of CKD defined by doubling of serum creatinine or defined as more than 30% decline in eGFR was 1.26. The risk ratio was 1.26 hazard ratio as compared to those who had used H2RA inhibitor. So the risk was higher with PPI, again could be related to the higher degree of acid suppression or could be related to the molecule itself, we don't know. And the risk of GFR reduction was also higher. This risk kept on increasing with the cumulative use of PPI. As the time passed and more cumulative use of PPI has done, the risk of doubling of serum creatinine or reduction in GFR was increased. Hazard ratio was increased in PPI user and H2RA user as compared to non-user. So the last part is PPI and the chronic kidney disease. It was a data from cohort of Veteran Affairs database, which included 20,000 H2RA user and 1,73,000 PPI user, and propensity score match controlled of 1,73,000, and followed their renal outcome for 5 years. Very good study. It has seen the various outcomes, renal outcome in PPI user as compared to control, and found that the PPI user had hazard ratio of around 1.5 to 1.8 of reduction of GFR to below 60, new onset CKD, doubling of serum creatinine, more than 30% GFR, and new onset ESRD. So different parameters have been seen for the chronic kidney disease, and everything hazard ratio was significantly higher in PPI user as compared to controls. The same study, if you compare PPI versus H2 blocker, the risk was higher, in PPI user as compared to H2 blocker. The same study has further shown that all this risk for all this renal outcome was increasing with cumulative exposure of drug use. As the duration of drug use, PPI or H2 or A increased, the risk of each of these outcome was increased. So now I will summarize in one slide how we are going to explain that PPI can cause all this renal outcome. The most likely hypothesis is that proton pump inhibitor, it causes hypomagnesemia, which you know better than me, that it is a risk factor for chronic kidney disease. Proton pump inhibitor itself or its metabolites, they are deposited in the interstitium. They induces inflammation, invites lymphocytes, which induce inflammation, and immune response causes interstitial edema, which establish the acute interstitial nephritis. If the onset is very fast or the nephritis is very intense, it can manifest in form of acute kidney injury, which can progress to chronic kidney disease, or gradually it can go through the stage of fibrosis, inflammation, and healing and lead to chronic kidney disease, which can end up in end-stage renal disease. Just in one slide, I would like to summarize the all data which I have shown till now. That the risk of acute interstitial nephritis is 3 to 4 times hazard ratio. Acute kidney injury is 2 to 2.5, and chronic kidney disease is 1.25. This gradient is also supporting that probably the first pathology is AIN, which gradually increases in a small proportion, worsen and progresses to chronic kidney disease in end-stage renal disease. So in summary, PPI are commonly prescribed to the patient with kidney disease, and a sizable proportion of such prescription can be avoided. Continued use of PPI for 6 to 12 months poses the risk for renal injury, which can range from acute intestinal nephritis to end-stage renal disease. And risk of renal injury increases with the duration of PPI use. And this burden of renal injury can be reduced by avoiding the unnecessary use of PPI. So in present era, judicial use of PPI is warranted, at least in those who are at risk of kidney disease. Thank you.